Now we're going to have an opportunity to ask questions. Our speakers are all going to sit up here. I'm going to stand here just so I can see people who are at the microphones a little bit better when they come up. But we wanted to start with a question for the panel, and you can jump in wherever you like. The first question I have is, how can patient navigation programs be better designed to address the needs of diverse populations?
Well, if everybody's going to be shy, then I'll start.
Go, Chris.
I think, you've heard a lot about tailoring specific, tailoring to specific populations. I think one of the things is to know your own population that you're interested in, and then specifically making sure that the navigators that are working there know that patient population. So, for my group, it was specifically, we knew that there was a lot of, Somali refugees as well as Dominican patients. And so we made sure that we went through and we wanted to make sure what those needs of those communities were. I think you can't just you've heard this over and over again today, you can't just put a navigation program in. You have to make sure those people are trained for the individual community.
Go ahead, I would just add stakeholder to that. And to reiterate that, stakeholder, just like Mr. Burns said, you really have to have Mr. and Ms. Burns at your table and a whole wide variety of communities and leaders sitting together.
That's great, because that actually leads me into my second question. You'd say that one thing we should do is have stakeholders there, that this is key, and talking to the communities that you're interested in. How could this influence actual policies about patient navigation? How can we get to the policy level? I think Ron Klein asked a good question earlier about, what would you like CMS to do about this? How can we make sure that we have the policies in place that ensure that we're reaching diverse populations and sort of promoting the equity using navigation systems?
So again, stakeholders. I have policy people, aldermen, reps at the table with us, learning together and weighing into the study design or the program design, and then looking at the data together. But one exemplar is in Illinois, our patient navigation data and all the other data I showed you really fed into a bill that became a law and passed in Illinois, one of the very few funded bills. It had patient navigation in it. So the Breast Cancer Treatment and Screening Quality Act. It's one of those landmark bills where we had the Illinois Department of Public Health and the Illinois Health and Human Services working together. And that was really essential. So that's one exemplar.
Just going to add on, you heard earlier today, I think Dr. Battaglia talked a little bit about this, taking the navigation work, working with the policy folks in your own state, and then developing policies going from that. And you also heard earlier today, I think Dr. Paskett was talking about making sure that, how do we reimburse this? I mean, this is a big issue. All of us are scrambling to fund our navigating, our navigators through different ways, whether it's through a study or whether it's through philanthropic funding. If there was a way that these could be billable, then I think you could see that this could be something that could be used not just by centers that have a lot of money that can incorporate things in operation costs, not just by really, great researchers, but really by everybody who needs it.
I guess two things. One, I think about humility, and I think about really kind of we can continue to talk to patients about where they are, and then we just really need to know that each patient's got their own individual story. So even though we can kind of make some generalizations and try and make culturally appropriate materials and interventions, each person's got to be the own voice in their own care, in their own care plan. And so just to kind of continue to talk about that. And one thing that we've done at Mass General is to really tie physicians, to tie kind of the salary to the amount of screenings that, so there are ways that we recently had a few vacancies of cancer in the cancer navigation team, and right away the adult medicine practice came back to us and said, wait a minute, we need you because like our productivity is tied to you guys, and and we're relying on you for our salaries, right? So it's become such a symbiotic relationship that in fact, in some of our other departments, the departments are actually chipping in money. So we actually have an obstetric navigator who helps underserved patients to, really, make sure that they're following through with prenatal care and postnatal care. And that's actually paid for by OBGYN. It's not paid for by us or any funder. So really kind of looking at a system and saying, how can this really improve outcomes altogether? Or, some policy things that might be helpful.
Yeah, great, thank you, because, we're going to have a later session where we talk about the metrics and the finances that make these programs sustainable. So I think we'll get into some more depth about that. But I see I have some people with questions. Go ahead, would you like to start?
Yeah, I'm Dr. Nguyen, Cancer Center Director from University of Illinois. I had a couple quick questions. The first one, though, I come from a state where we didn't have a budget for 2 years. And so that was kind of interesting when you make NPR for that. But the question I have is in the context of Massachusetts, what effect, if any, did Romney Care actually have on your ability to sort of carry through sort of your programs with navigation?
Thank you. No, so there are two. I think this is just my opinion right now. I think there are two things. One, on one level, I think expanding universal access, making it it's less than 3 or 4% people who are now completely uninsured. Now this is not and I think that has helped. That has helped dramatically and allows us to do some things that other states can't. However, it has also uncovered that even in a state that has 98% coverage for insurance, there are still major issues with access. So there are two things, right? Access is important, and I think the Romney Care has been very helpful to expand access. The other thing, if you look at some of the data, ED visits went up. We still have a capacity issue, I guess is what I'm saying, and that the insurance was helpful, but it didn't take away the disparities completely.
I guess going back in time, I would actually, Massachusetts has always had a huge safety net for and even before Romney Care. So I think one of the things that was really important in this journey of kind of how to address disparities and navigation, you kind of go back 22, 23 years when Attorney Scott Harshbarger was the Attorney General. So at the time, the Boston Globe put this spotlight out that sort of said, like what we've heard about today, here in Massachusetts, there's all these, the infant mortality rate was really high, all these, but yet here are these major academic teaching hospitals. So what is going on in this, so sort of to kind of raise a spotlight on really what's going on. And then through community benefits, the community benefit guidelines, actually, all the Massachusetts hospitals got together and turned some of that tax saving dollars back into the community. So there was like a really, really big effort sort of going way back through community benefit guidelines to really make the hospitals accountable to use that money back into the community. So Massachusetts, Romney Care is fabulous. It's made a big difference. But I think even before that, Massachusetts has had a really big safety net. So a lot of, in Chelsea, patients always could walk in and get care. We care for a ton of undocumented patients. And, so even well before Romney Care, the free care that was always, patients were always eligible to kind of come in and get care. So,
thank you. I'll hold my other questions for you offline.
Okay. Go ahead.
Hi, I'm Amy Fitzpatrick. I am an internist and primary care doctor at Boston Medical Center, and I also work in the breast clinic there. I clinically supervise our navigator. And I had two questions. One was, how are your navigators tracking patients? The more I ask this question, the more I realize that although we're all tracking patients, we're all doing it in very different ways. So I've heard everything from Excel spreadsheets to Outlook calendars. We use a hybrid of documenting in the electronic medical record and then extracting it into Excel. So that's my first question. And then my second question was actually for Sarah, and it was just, it seems like you guys have navigators that are maybe touching on a couple of different, they seem to be navigating a couple different areas, and I'm just wondering who clinically supervises your navigators? So those are my two questions.
So I might be able to answer the first one as well. So we actually have moved through various systems. Now we're actually documenting our work in Epic, right, directly in the electronic medical record, because it's easier. So, if there's any way, any sort of information that we can share. But when our community health workers meet with a patient, they go through a whole kind of social determinant of health screening questionnaire. When we're just working on navigation, there's fewer questions because we don't, necessarily get into all that right away, in terms of all the social determinants of health. But any of this I'm happy to share. And sorry, your second question again was what?
Oh, just who clinically supervises
Oh, okay,
your
I'm sorry, yeah,
navigators?
right, that was most important, right. So I actually have a team of managers, several of who are social workers themselves, but they're supervisors who manage community health workers. So they themselves have had a lot of training on what that means. So we use three kinds, and I can talk about any of this offline and share any of this, but we use actually 3 techniques for supervision. Obviously, administrative supervision is, kind of, are you, making contact with the patients, what's going right, what are your numbers, all that kind of stuff. And then clinical supervision is actually looking at a chart together with a navigator or a community health worker and sort of going through what are next steps, if there's patient barriers, how do we break those down? And then one of the most important things we found is a technique called reflective supervision, and it's actually a model that comes from the Healthy Families America, which is an early childhood prevention, early childhood home visiting model. So Healthy Families America has sort of coined this term of reflective supervision, which is meeting with a community health worker or a patient navigator to talk about what's coming up for them and to give space just to have it be safe, to have conversations around, oh gosh, I'm kind of curious. You seem to really want this patient to be doing this. Where does that come from? Where does that come from? Is that patient maybe reminding you of your grandmother? What's being raised for you when you're working with this patient? And how can there just be a safe space to talk about it? So it's kind of creating a reflective practice where community health workers or patient navigators know that they're going to have supervision every single week, that they've got a safe place to come and to bring things to. Of course, there's things that come up throughout the week as well. But just to really make sure that there's enough time for ongoing supervision to really deal with what's coming up, not only for the patient, but also in the kind of parallel process, what's happening for the community health worker or the patient navigator. So it takes time, but it's really important. That's how they can be successful. Is that an answer?
Okay, great, thank you.
Hi, my name is Paul Scribner. I'm Senior Director of Patient Advocacy at the Aplastic Anemia and MDS International Foundation. So basically bone marrow failure diseases. So my question, or it's really an observation with sort of an embedded question. In the community, when I go out and I'm seeing patients, we do conferences throughout the year, I often hear, especially from the MDS patients, that they're initially being seen by a community hematologist. And I occasionally hear that the community hematologist is reluctant to refer to a major treatment center. And most of what I've heard here today is patient navigation happening in the context of a major treatment or a teaching hospital or treatment center, some community-based navigation. So there's reluctance to refer. And so the question that I have really is, have you seen sort of models that might be like a hub model that provides patient navigation services for a variety of community hematology practices that maybe is not tied into necessarily a major treatment center like Dana-Farber or something like that? So I'll just put it out there and for comment and discussion.
Yeah, so I apologize for not being clear, but the models that I showed, none of them led to Northwestern.
Okay.
They were all with so the work that I do is very community-centric and specific. So the DuPage one was at the county level with Access DuPage, a 501c3 community organization, serving as the hub for the community, the navigators and lay navigators, and literally finding women through canvassing across the areas of need in that county, and then working with the variety of doctors who were either volunteering free care, or the hospitals, because there's no county hospital, or the clinics. There were only a few, 2 to 3, then 3 at that time, federally qualified health centers, and only 1 free clinic. So they were moving around that area. In Chinatown, the care again is with the community providers and the community organizations in Chinatown in the city center of Chicago, along with the local community hospital. Nothing was going to Northwestern Lurie Cancer Center. Same with Sinai. The third example I gave was with the community hospital Sinai, along with their outpatient clinics in that area on the west side of Chicago. So does that help? But it definitely can happen. It's very different than the original Patient Navigator Research Program, the original UO1 that Dr. Pesquet had referred to earlier this morning, whereby most of that was within the medical centers. Those 9 sites really started from the academic medical centers. But again, a lot of the programs there as well had community sites and clinics.
Yeah. Just to follow up, just quickly comment that we of course, always suggest that these patients do go see a specialist that can then work with their community hematologist, but that doesn't always happen.
Their big challenge is making sure that the patient who has a primary care medical home and that particular clinic, regardless of where it is, needs to stay connected with wherever that cancer care is happening. And that's a big gap right now in care provision. And how you do that, and that was what I was speaking to in terms of care plans and sequences of care, starting that care plan in the clinic as opposed to the tertiary cancer care center.
I just wanted to kind of, so this is tricky, right? Because, I think there's a natural tension here between, there's a feeling that, especially for the large academic medical centers and the large cancer centers, that they steal patients from the community. So there are places that are taking care of these patient populations, whether it's vulnerable patient populations or rural patient populations. And let's say you have so you should be seen by the expert in this. They go see them and then they don't come back. Now, sometimes they don't come back because the patient wants to stay. Sometimes they don't come back because the system inertia keeps them there. And then that actually says, if you're the community oncologist, why am I going to send over there if I'm not going to get the patient back? So this hub model that you talk about requires 2 things. It requires, we need to stop thinking, and it's easy to say and hard to do, about what's better for us, community oncologists, the specialists, and get together and figure out what's right for the patient. What's right for the patient might be to stay in the community for as long as possible until they need this expertise that's only provided at this other place. We also haven't talked about restrictive insurance policies, because there are patients that need to go to a certain place to get a certain thing. Let's talk about bone marrow transplant, for example. Sorry, you can't get that in their backyard. So, but, how do you navigate that? And because, cost savings are often taken out on the poorest, so you're restricted, you can't go in there because we don't want to spend on you, but rich people always get to choose where they want to go. And I do think we have to think about that natural tension there.
Okay, thank you. Next.
Hi, my name is Kathy O'Doherty. I'm a nurse navigator. I actually have a unique position which kind of ties in with what you're talking about. I'm co-employed by 2 health systems. Mainline Health, which is a system of 4 hospitals outside of Philadelphia, and Thomas Jefferson University Hospital. My job is to navigate patients between the 2 systems for needs that each doesn't have, mostly going from Mainline to Jefferson for things like the different transplants, et cetera. And I follow them and get them back to their starting place so that they don't get lost in the system, so that the community oncologists are not trying to keep them there because they don't want to lose them in the system. So I've been doing it for about 7 months, and they're pleased with how it's going, so they may start extending this into other specialties other than just oncology.
All right, thank you. Go ahead.
Hi, my name is Lauren Malloy. I am a patient navigator at Johns Hopkins University in the Division of Thoracic Surgery. And I had a question, I'm going to say in Dr. Christopher's presentation, because I'm not sure how to pronounce your last name. But you had mentioned that there was this on-site smoking cessation At Hopkins, we do have a lot of services, supportive care services for oncology patients. And I wondered if anyone had looked at, had either done research or has patient navigation programs that incentivize patients following through with care. So for instance, like I know some managed care organizations have cash incentives for patients, like prenatal women who attend all of their prenatal checkups. So I just wonder, just sort of throwing it out there, if anyone had looked into using that as a way to help promote follow through and ultimately outcomes.
So in the tobacco cessation literature, there have been some people looking at different incentives. The problem has always been, one, there's a budget issue with that, right? But the other thing is that it's all depending on where you are in your addiction cycle. And I think that's the problem that we find. It's not necessarily, if you talk to the patient at that moment and you would incentivize them to make an appointment or to go to one appointment, yes. But the question is, will they be able to follow through continually? Are they ready? Are they ready to quit smoking? And I think that's the part that's hard. And there's a lot of people, Nancy Rugati actually at MGH does a lot of research on this, on tobacco cessation and the best way to motivate people. We're still working on it. Incentives help, but they're not as clear cut, at least in the tobacco literature.
Thank you.
Go ahead, Linda.
My name is Linda Horn. I'm a patient survivor and a past hospital CEO. So my question is to Dr. Fisher. As much as we've seen families and patients who struggle with that decision about hospice, I've seen many physicians struggle with that. When is it the right time to offer that to their patients? So what do you do to get the physicians to start looking at the prognosis as opposed to the diagnosis?
That's a great question. It's interesting. I've mentored some other researchers who've been looking at this. And any time that anyone suggests that I mentor, let's do a physician education intervention, my head collapses. I think it's a really big challenge, and I don't have a great answer for that. What we do and what our navigators have done is, rather than interact directly with the providers, is to activate the patients, to ask the right questions. And hoping that what we're really doing, we talk about tertiary palliative care. That's someone like me who's a trained specialist. We talk about primary palliative care, the oncologist or the heart failure doctor or the primary care doctor who's doing that primary palliative care. I think of our navigators as pre-primary palliative care, that they are kind of priming the pump on their providers to do that. Prognosis is a tricky thing. We're optimistic. Providers tend to overestimate it by 5 to 6 times. And I don't know that we're gonna move the needle on that. So it's to have patients asking the right questions and teaching providers to talk about goals and values, to try to get that answer better.
Thank you. Go ahead.
Michael Gardiner from Pragmatica. I have a question for Sarah Wu relative to the community in the neighborhood of Chelsea Healthcare Center. What has been your experience about any possible cultural or language barriers in terms of communicating with patients relative to the navigators? And has there been any efforts to match prospective patients with prospective navigators in that regard?
Yeah, so we do actually hire directly from the community. So the navigators are actually speaking the languages that the patients. So oftentimes when we're looking at the pool of community health workers or patient navigators, honestly, they may have been former patients who came over as refugees who we sort of met in the process, we're trying to be very creative where we're finding our candidate pool from, because we do need to be so diverse on that. So yes, we are absolutely, matching up patients who have the same language, the same ethnic background, the same religion, the same whatever, because it just, we've found that it works better that way. Yes, so if that answers your question, yes,
Thank you.
we're doing that.
Thank you. We have time for one more question.
Hi, good afternoon. I'm Arti Varanasi with Advancing Synergy, and thank you for a very engaging and informative panel. So my question centers around, each of you talked about cultural competency and meeting the patients where they are. I think part of that, of meeting them where they are, is related to their health literacy. So even if you're meeting them with language and meeting those needs, they still may have different health literacy levels. Have you seen that? And if so, how have you been able to address that?
So we actually had, again, I don't make a generalization on a whole group of people, but we actually found very significant health literacy issues when we were talking about the particular Somali Bantu patients that we were working with. We were trying to talk about cervical cancer and the importance of pap smears. And we really had to start with, where is your cervix? And I mean, really, it was like, not only what is cancer and why is that something that, but then you get into all the, I think Stacy had mentioned, I don't even want to be tested because I don't want to like jinx something. You had a group of people who, it's very even hard to have blood drawn because their blood was sold. So the kind of the fear and the stigma, but really starting with, I mean, even a gynecological exam, but sort of why is that important? And that's an area that nobody even wants to talk about. But sort of literally even what is a cervix and why is that an important thing? So yes, we've had really a lot of challenges that way.
I just want to jump in. We also kind of, the first thing our program nurse does is we actually do literacy checks. So some people, there's a post-prison release program that is actually at the health center as well, and there's a lot of men who didn't like to admit that they were functionally illiterate. And so we've actually set up our consent forms and all that. We have different levels for people. And then the other thing is, in the room, a lot of the times we are usually re-explaining a procedure that a person already had, because they'll say, "Doc, nobody ever broke it down that way." And that could be, they went to another place, had exactly what they were supposed to have, but they didn't understand it. And it's not that physician or that provider didn't explain it to them, it's just that it didn't kind of come in for them. And I would say that that's probably about 60% of what we're doing, is trying to figure out what's the best way to explain it to this patient, which is not necessarily the same as to another patient, but the literacy level is assessed. And somebody asked earlier about how we record our data. We actually do it in REDCap. We actually take the whole intake form and do it in REDCap, and we have 2 separate databases that are linked by a unique identifier. So we could talk offline if you want.
And it's more than just health literacy. There's numeracy, there's financial literacy that speaks to the financial toxicity issue, and there's also research literacy because of the clinical trial aspect of this. So there's a lot of realms of literacy that we have to be aware of, and we absolutely incorporate those into our work.
Can I just say one thing about the incentive thing? I feel incentives are really tricky because you don't want somebody to do something just because of an incentive, but really meeting a patient where they